going to talk about features of IBD, therapy and advances of IBD, and the QI project that we have been doing. So IBD, as you know, is a chronic inflammation of bowel. You see ulcerative colitis, which is colonic involvement, and Crohn's disease, which affects the entire GI tract. The clinical features are abdominal pain, diarrhea, bloody stools, weight loss, mouth ulcers, and perianal lesions, because it affects from mouth to the bottom. And there's a reason I have underlined these symptoms and put a star, because these are the things we are going to measure in the QI when I talked about the QI. So keep an eye on those. Ulcerative colitis causes diarrhea, abdominal pain, rectal bleeding, nocturnal diarrhea, and weight loss sometimes. Main problem, one of the problem, even though I talked about obesity and IBD this morning, many kids have problem with the weight gain. They have poor weight gain or weight loss. They get anemia, they get vitamin deficiency, they get hypoproteinemia. So it's really a complex disease which affects many problems. I think this slide I showed you this morning, it causes impaired linear growth. Again, that's something. So when we measure the outcome of our care, we really want to look at all these things. So IBD is a disease, it goes remission and relapses. So it gets flare when you have a clinical symptoms and growth failure, and remission is what we want to achieve when kids have no symptoms. They don't have pain, they don't have diarrhea, they are feeling well, they have a good energy level, and they are growing well. And that's our aim. So in the treatment, we have different medications, mesalamine, which is 5-amino-salicylic acid, steroids, immunomodulators, biologics, nutritional therapy, and surgery. So 5-ASA is a topical anti-inflammatory medication, oral. It can be given oral or rectal. It's usually used for very mild disease, and you can use it for long term because the adverse effects are very mild and the side effects are very rare. And this is the dose that we use, 30 to 70 milligrams per kilo per day. Second medicine, prednisone. We all know prednisone is a very strong anti-inflammatory medication. It's very good for acute relapses. But the problem is it has a lot of adverse effects. It can cause acne, Cushingoid feature, hyperglycemia, growth failure, infection, bone problem. So very important, in the treatment of IBD, we do not want to use steroids for a long time. So avoiding long-term use is one of our goals in taking care of children with IBD. Then we have immunomodulators like 6-MP, azathioprine, and methotrexate. And these are good for moderate to severe disease and prevention of loss of response to biologics and prevention of post-op recurrences. These medications can be associated with significant side effects, like they can suppress the bone marrow, they can cause liver and pancreatic toxicity, rarely it can cause lymphoma cases, methotrexate can cause nausea, hepatotoxicity and pulmonary toxicity, and rarely can cause cancer. So it's very important that we use these drugs appropriately. We use the appropriate dose and we monitor the levels, because these drugs we use them and they can cause significant side effect, causing healthcare problem to our children. Then we have biologics, which are anti-tumor necrosis factor agents. These include infliximab, adalimumab, and sometimes we use combination therapy. So infliximab is an IV infusion. We give it over 2 years over 2 hours with pre-medications, and the dose has to be between 5 to 10 milligrams per kilo per dose, because that's shown to be a very effective dose, and that's something, again, is one of the parameters that we monitor when we do our QI methodology. Generally it does not have any problem, but can cause hypersensitivity reaction or infection, and may lead to loss of response. It's very important, even though in USA it's not such a problem, we have to make sure that the TB is ruled out, tuberculosis is ruled out before we start biologics. How do we improve outcome in children with IBD? So there are 2 ways. One, we can use advances in therapy. That means trying something new, which is experimental and thing. But second thing is just by using quality improvement method, where we use the same therapy. We don't change anything. We have the same medications, but we just use the quality improvement, and I'm going to tell you about that. So what are the recent advances in IBD therapy? One is we know that combination therapy that we can use. Second is we can start monitoring the anti-TNF therapy. Third is sort of new agents, which are mostly used in adults, but soon will be available in kids, and the enteral nutrition. So combination therapy, there was a huge study called SONIC study, which was published in New England Journal. It was an extremely well-designed study where they took adults and put them into 3 groups. One was infliximab group, one was azathioprine group, and one was combination group. And they showed clearly that the combination of azathioprine and infliximab was way better than infliximab and was way better than azathioprine. And since then, we've been using this combination therapy. But one thing we realized that azathioprine or 6-MP can cause cancer, so we are mostly using the methotrexate along with the infliximab or even biologics. So this combination therapy has been shown to be very effective and can keep our patients in remission. Second thing we learned recently over the last few years is the monitoring the Remicade level. So this was a one study which they had 72 patients and they had 191 serum levels. And when the levels, infliximab levels went down, they adjusted the dose. They increased the dose, decreased the duration, and they found that that way we can improve the remission. So doing this can also improve the remission when you monitor your drug levels. That can be pretty expensive though sometimes if you do too many drug levels, because those are very costly. Then there are some new agents which are used in adults and soon will be available or almost available in children. Vedolizumab or Entavio is an anti-integrin antibody. Ustekinumab or Stelara, which is interleukin antibody, and tofacitinib is a JAK inhibitor, and these are showing really promising studies. So these, if you use this, you can improve your remission. And then the enteral nutrition, which is very common in Europe and Canada, where it's almost as good as steroids, but without any side effects. And we've been using addition. We use our medication and we use enteral nutrition. And so together we can improve the benefit. But now we can just use the QI principles using the same therapy as I mentioned before without using new therapy. And I'm going to show you how our results are. So IBD is a great chronic disease model. It's a lifelong disease. It relapses, it remission. There are growth issues, so it has complications. You have multiple medications to choose from. Some of them have adverse effect, and these children need regular follow-up. So there are many different things you have to think of when you take care of child with IBD. What's our treatment aim? We want to keep the patient in remission. We want the remission to be steroid-free, and we want it to be long-term. We also want to achieve satisfactory nutrition and growth status. And we want to do this using medications appropriately so that they don't cause any side effect for the child. So what is the QI principle here? We want to achieve outcome using consistent evidence-based diagnostic and treatment guidelines. We want to measure our outcome because without measuring, we don't know where we are, and ongoing QI improvement to improve outcome. So one of the QI principles is we cannot improve what we cannot measure. So you have to put an objective measure to this. I run the pediatric IBD program at Yale. So we have multiple missions. We have education, research, clinical care, QI, and patient support. And I'm going to talk a little bit more about the QI now. So we are part of this multi-center international QI project, which is aimed to improve care for children with IBD. There are 87 centers and 2 in UK, and it's a large database which is housed in Cincinnati. What do? We have established model care guidelines on diagnosis, therapy, medication dosing, nutrition, and growth monitoring, and we assess ourselves, like the whole network assesses all the centers on this. What else we do? We do pre-visit planning. So when we have a Tuesday morning IBD clinic, so on Friday before, we go over the patient, we have the pre-visit planning form, so we know which patients, maybe patient needs endoscopy, maybe patients need nutritionist, patient needs MRI, patient needs steroid to be taken off, this patient needs different. So we talk about it and we come up with a plan during the clinic visit. Then we have a data entry at every patient visit. Then we do population management. So at any time we know which are our patients sick, so we can concentrate and focus our resources on that. And we do what we call as PDSA cycle, that is plan, do, study, and act. So these are all the QI principles. So as they say, in God we trust, but for everything else, show me the data. So these are our results, and I'm going to walk you through this little bit. So this is our data from compared to network. So here we have. So on the left side, these are the clinical measures. These are the measures where how patient is doing. These are nutrition and growth. This is model classification and model treatment, and this is the data quality. So as you can see here, there are % of patients in remission, % of patient prednisone free, sustained remission, long-term remission, how are they doing with nutrition and growth, how are we doing with the medicines, and so we get assessed on this. So this is the network target. The network target is % of patients in remission, they want to aim at 80. And these are the various targets they mention. The second column is centers which have enrolled more than 75% of their patients in this network. So these are the large centers, active centers who are putting a lot of effort in this. And the third one is our team performance, that is Yale performance. And as you can see, we've been doing really, really well. The green is really good. So we're doing much better compared to the network. Then we have the yellow ones, which we are not doing as great, and we could do a little better. And then there's this yellow here, and that's probably my action because I really don't like the medication thiopurine at all, so I don't use that often. So I want to show you that we, using this evidence-based guidelines with QI principle, we are doing really great compared to our network. Now I want to show you how we are doing ourselves. We started participating in 3 years back, and this orange line is the network target. And as you can see, at Yale, we are doing really well, and most of our patients are in clinical remission, and we have maintained our rate at 88%. So 88% of our patients are feeling well. This was from the May 2016, without any symptoms. They have good level of energy, and they're doing well. And we are doing this without prednisone. We are very particular, very aggressive about not using prednisone. So we adjust our other medications and do that. So these are the patients not taking prednisone, so which are higher than the network target. Sustained remission, that means patients who are in remission for more than a year. And the network target is 55% because it's very difficult. These patients do get symptoms on and off. But if you see them regularly, if you act very quickly, we can keep them in remission. And our target, our rate is around 55% or something compared to, no, our rate is almost 60% close to. Nutritional status is where we were not doing well. Over last year we struggled, but we have our nutritionist and we did a lot of intensive bombarding of information, getting very actively looking, seeking these patients, and now we are the same thing at nutritional status. Regarding growth status, we are a little behind the network and we are working on this, but we have been around the network. How good is the data we are sending? Our completeness of bundle is most of the times pretty good, although sometimes we've been slacking. We have done our own QI project. So this was at a big level, like multi-center international QI project. And we did our own QI project, as I explained to you, with the plan, do, study, act thing. This was a mesalamine dosing. In a couple of years back, we make sure that 90%, more than 95% of our patient will be on adequate dose of mesalamine, and we do this with a couple of PDSA cycle. Last spring, we wanted to check the vitamin D levels, and we again did that over time. And this is the run chart, which is another QI methodology, and we achieved that aim over in the spring. So what does this do? Quality improvement. As I said, we are not using any different medication. We are not using any of those new medications that I told you about. This is a quality care which benefits patient, improves outcome. We are not, it's a cost effective. We are not using too much extra medicine or fancy medicines. And it's very important in the United States, particularly when the government programs and insurers really demand quality, and they want to pay for performance, where you'll get reimbursed if you show good quality, and this really satisfies that. I want to acknowledge my pediatrics member, my pediatric IBD team. This is our team that my co-director, nurse, dietitian, gastroenterologist, and fellows. And thank you for your attention.